Good morning, everyone. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at our Department of Family and Community Medicine at the University of Toronto. I'm delighted that our department can continue to bring you these sessions together with the Ontario College of Family Physicians. And I'm going to turn it over to their president, Mehalay Kumanen, to introduce the session. Mehalay?
Thanks, Tara. Good morning, everyone. Thank you all for being here with us. I'd like to take a moment just to thank our panelists. We've got a really good session lined up for you today. And just a reminder, this is a Maine Pro accredited session and you'll receive details by email. Next slide. So just moving on to our land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from Kitchener, the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the Neutral people. Next slide, please. Thank you. So I just wanted to take a moment to reflect on our land acknowledgement. This is an opinion piece that was in the U of T's student newspaper, written by Angie Hunda, just in January. And she speaks to the challenges in our healthcare system in terms of meeting the needs of the Indigenous people in Ontario and some of our rural and northern communities, and just the importance of trying to recruit Indigenous students to healthcare who may wish to practice in their own community. So as I reflect on this, just, in the context of our current crisis in our healthcare system, and particularly in family medicine, I think it really is important for us to think specifically about how to meet the needs of Indigenous people in Ontario, and specifically to ensure that they are represented in our healthcare system. Next slide, please.
Thanks, Mehalay. So we're looking forward to today's session. Just a reminder that today's session, the recording along with the slide deck, a summary of the Q&A and the resources will be posted on our website. And usually it's posted the same day with the exception of the Q&A, which takes us a few more days. A huge thanks to our planning committee who continues to pull these sessions together. And if you have any recommendations for future sessions, please do let us know at the evaluation stage. Also, these sessions do build on one another. And so as we'll talk about, we're not going to do a deep dive into where we are with COVID or the latest on vaccinations today. If you're interested in that, we had a terrific session a few weeks ago, which you can access on the website. Next slide. So I'm excited to have our panelists introduce themselves shortly. Next slide. And of course, delighted to co-host the session with Mehalay. Next slide. So Kieran, I wonder if you could start.
Thanks, Sarah. Good morning, everyone. Thank you so much for joining us this morning, and it's an honor to be here and present to you. My name is Kieran Quinn. I'm a clinician scientist in Toronto at Sinai Health and University of Toronto. I practice as a general internal medicine and palliative care specialist at our two hospitals. My disclosures this morning, I received grants and research support for our work around long COVID from the Canadian Institutes of Health Research. There's an honoraria for today's talk, and I also work as the assistant scientific director of the new science table, so to speak, called Ontario Public Health Emergencies Science Advisory Committee, and so I'm employed through Public Health Ontario in that regard. And then in my personal portfolio, I have own stocks in Merck and BioNTech, who manufacture COVID vaccines and other treatments, and so those are my disclosures.
Thank you. David Kaplan's going to be joining us at 8:30, and he's listed his disclosures here. He's a vice president at Ontario Health, which is his main conflict or main disclosure. Gary?
Yeah, good morning. Great to be here. I'm Gary Block. I'm a family physician in downtown Toronto, St. Michael's Hospital. I am with a group called Intercity Health Associates that provides care in homeless service settings. I also do research, educational curriculum development, and some social policy advisory work, mostly around social determinants of health and poverty and income supports. I have received supports from various organizations, most of them within our family medicine world. I don't think any of them offer any particular conflicts for today's talk.
Thanks, Gary. Mehalay?
Hi, everyone. My name is Mehle Kuminen. I'm a family doctor in Cambridge. I also serve as a chief of family medicine at the Cambridge Memorial Hospital and the president of the OCFP, neither of which poses a conflict for today.
And I'm Tara Kieran, and I've listed some disclosures there, largely related to grants and research support, and some speakers honoraria, but none of these pose a disclosure conflict for today. Next slide. So welcome, folks. You guys know that what makes this session special is all of the interactivity. So just a reminder to put your questions in the Q&A, and we'll do our best to answer them through the sessions. We prioritize the questions that have the most upvotes. So instead of typing in a new question, if you see someone else has asked a question that's very similar to yours, give it a thumbs up and we'll prioritize those ones. Of course, we also always love learning from each other and from your experiences, getting your reactions, and those are wonderful things for you to share in the chat. Next slide. So without further ado, I'm going to turn it over to you, Kieran, to get us started.
Thank you, Tara. And again, good morning, everyone. It's really an honor to talk to you today. And, you know, when I was asked to participate, it was actually quite a challenge to think about what to talk about with long COVID, because there is just so much to give people an overview, and yet we understand still so little about it. But what I'm hoping to do is give you some practical advice based on my personal experiences in looking after patients and doing research, as well as those of the national network that's come together across Canada. And so collectively, we've come up with some guidance that I hope will be helpful in your clinical practice in looking after people living with long COVID. Next slide, please. So I thought it might be helpful to start with a case. I've changed the initials and some of the details, but this is a real person that I look after, and this person has given me permission to talk about it in this way. So he's a relatively young man. He's 42, and he had typical symptoms of respiratory viral illness with COVID and a positive rapid antigen test at home in July of 2022. His past medical history is rather unremarkable. He has some white coat hypertension and anxiety at baseline that was well controlled and treated with medication. In fact, so well that he came off of medication prior to his infection and wasn't on any medicines when I first saw him. He had been vaccinated 3 times prior to his COVID infection with approved vaccines in Canada. And he's really a loving and dedicated husband and father to his 2 young kids. He coaches hockey and he's quite active with them. He's a very high performance, very active man. He's a high performance endurance athlete. He trains in triathlons and marathons, and he's had quite a successful career in finance, which is a relatively high pressure job, and he deals with a lot of people's income. Next slide, please. This is a visual schematic that I've drawn just to give you a sense about his course as far as his functioning and sort of ability to carry on his day. So the far left there, you see he had his initial infection in July of 2022. And, he had about a typical week of symptoms like many of us do, and things started to get better. And so he went back to exercising and starting to retrain for his triathlons. And then he found about 3 weeks after that things really started to go downhill for him. And he would find that even going for a walk with his daughter, he would come home and he would have surges of these symptoms and really be kind of down and out for a day or 2 after that. He also noticed some new palpitations that were coming up, and his anxiety was starting to flare up again. 2 months later in September, when I touched base with him again to see how things were going, things were not going so well. He had sort of stabilized a bit into this relatively lower functional state, but then new symptoms of shortness of breath, and particularly when lying down, began to pop up. And things just then continued to get worse from that point on, so much so that he wasn't able to continue his job, and he felt really uncomfortable in managing people's finances, that he couldn't focus, and he would be left debilitated after a particularly stressful day. So he applied for disability insurance just recently, and in fact was denied by his private insurance company. And so I've been helping him along the way to try to manage some of these issues. Next slide, please. At our exam in September, so just prior to 3 months after his infection, he looked pretty well. He was a bit anxious and worried about the future, but we did a 10-minute standing test whereby you take a resting blood pressure and heart rate, And then you, every minute after standing them up, you do that for 10 minutes and you ask about symptoms and measure their heart rate and their blood pressure to look for POTS or other dysautonomic features. And he didn't actually meet the criteria for POTS, which is a resting heart rate change of about 30 beats per minute when he stands up with no change in his blood pressure. But he was quite symptomatic with orthostasis, and he had a relatively robust change in his heart rate, just not the criteria of 30 beats per minute. His routine blood work at that time was normal. I sent him for a 48-hour Holter. This is not an endorsement of the company M Health, but they are a company I use a lot because they're OHIP covered, but they'll actually FedEx a Holter monitor to people, and they just simply FedEx it back. So for people with long COVID and a lot of this post-exertional fatigue, I find it more helpful than having to go to a Holter center to pick it up, and they operate all over Ontario. That Holter just showed some premature atrial contractions, PACs, but no arrhythmias otherwise. And when he developed shortness of breath lying down, we were worried that he may have had a cardiovascular event. So we sent him for an echocardiogram, and that was reassuringly normal. Next slide, please. So really his ongoing issues, to summarize overall, he has continued profound fatigue and exercise intolerance. This is particularly worse after even minimal cognitive or physical activity. And he finds that also his symptoms worsen during this time. He has the symptoms of orthostasis, and we're worried about dysautonomia and possible POTS. He describes brain fog. He calls it brain fog, or memory impairments and difficulty functioning his day at his job. His anxiety has gotten worse, so much so that he's found now he's had difficulty sleeping. He had questions about vaccination for me after he's sort of developed what we think is now long COVID, and he has ongoing issues trying to support himself financially with his recent denial of disability claim. Next slide, please. So I wanted just to give you a bit of a whirlwind, and it's broken up into 3 parts. We published a series in the Canadian Medical Association Journal, myself and Angela Chung and Fahad Razek, that are organized around this framework. So I thought I might take you through that. So let's just focus a little bit on the diagnosis. The leading definition, which is a clinical consensus case definition that was developed by the World Health Organization and was a Delphi process of many different experts, including people with lived experience, are that long COVID is that people have persistent symptoms 3 months or longer after a suspected or confirmed SARS-CoV-2 infection. So the key there is suspected. They do not have to have a PCR or a rapid antigen test to prove that they had it. That's where the doctors come in and say it sounds pretty typical. That those symptoms last 8 weeks or longer in duration, and that it's not explained by an alternative diagnosis. And I think that's where I think many of us find challenges. So we'll come back to some guidance on that. In our neighbors to the south, the Center for Disease Control still maintains a slightly different definition. The timing is different. So they'll talk about symptoms that are 4 weeks and beyond the initial infection. And on top of symptoms, they actually include worsening of pre-existing or development of new health conditions that may be causally associated with the SARS-CoV-2 infection. So timing and symptoms are the key difference. In Canada, we've adopted the WHO's definition, which, by the way, is still in flux. They're updating it and trying to refine it to better reflect what's going on in the world. Next slide, please. This just gives you an overview of how common long COVID is. And these are 3 national household surveys that were done in the past year in similar jurisdictional countries like the UK, the US, and ours. So the Canadian COVID-19 antibody survey that was done by Public Health Agency of Canada and StatsCan. It's a self-reported survey according to the definition of the WHO. And that revealed that about 4.6% of the Canadian population, or 1.4 million people, reported that they had lingering symptoms 3 months after their infection. That translates to an incidence, so how many people, what proportion will develop long COVID after a SARS-CoV-2 infection, of about 15%. And while the UK didn't report on incidence, the US household survey did, and it's very similar to what we see in Canada. Prevalence numbers are slightly different because the US experienced a much higher burden of infections. I think we did a pretty good job around prevention in Canada, and so I think our prevalence is lower as a result. Those last two boxes, just to give you a sense about a prognosis. So almost half of people still report these lingering symptoms after a year. And a fifth of them, about 20%, indicate that those symptoms are severe enough that they limit their daily function on a daily basis. Next slide, please. This slide just gives you an overview about what our current understanding is around the mechanisms that might lead to long COVID. And these are not definitive, but they're the best understanding we have to date. On the left, you see a visual schematic that's color-coded on the density of the expression of the ACE2 receptor. SARS-CoV-2 virus enters the cell through ACE2. And what you see here in that picture is that ACE2 is almost ubiquitously expressed throughout the body. And that's why we think that long COVID is a systemic illness and a systemic disease, because the virus can enter almost any cell in the body through the ACE2 receptor. These four color-coded boxes in the middle are the mechanisms by which we think people develop those persisting symptoms. And so on the top, there's this idea of viral reservoirs and viral persistence, that perhaps components of the SARS-CoV-2 virus or entire viral particles itself are able to find reservoirs, say, for example, in the gut, where there's been some biopsy studies showing this in people with ongoing diarrhea. And perhaps that is some mechanism by which the virus causes ongoing problems and symptoms as a result. Uncontrolled inflammation and persistent inflammation, which is common in many infectious illnesses, and the system just isn't really able to turn it off even after the virus is cleared. And so we think that potentially these persistent inflammatory responses are leading to damage and symptoms. There's been a lot of work, especially out of McMaster, that's been really helpful to show that there's the presence of autoimmune antibodies, and there's some thought that there's an autoimmune process that's at play here and causing ongoing inflammation and damage. And then this idea that there's microvascular clots, so, tiny blood clots that are not picked up by our typical angiogram or other diagnostic testing that may be leading to damage and ischemia in different tissue beds and resulting symptoms as a bot. Now, these are not necessarily mutually exclusive, and not everybody has each one of these different pathways. We're still trying to sort out which are the predominant ones and which ones can be treated and modified. And that's some of the work that's ongoing around trials. Next slide, please. There's been a lot of work trying to identify who is most at risk. And the takeaway from this slide is that female sex as a biological measure appears to be the most predominant and most consistent risk factor. And I think if we think about the roles that females and those that identify as women or other gender roles in our society, there's a major equity and impact consideration here. And that it's consistently been shown that females are more likely to develop long COVID according to current definitions. There's some suggestion around socioeconomic factors, but that still appears to be a little bit in flux. And so I think the key takeaway here is that female sex is the single identifiable independent risk factor. Next slide, please. Beyond health effects, there are downstream and knock-on effects when people are disabled and not able to work. This study just came out of the United States, and it's one of the best I've seen to date around how likely people are to be working when they have long COVID. And so this study looked at people who were working prior to the development of long COVID. And then once they developed long COVID, it followed them and asked about whether they were still employed. And in an unadjusted analysis, there was a 29% lower odds of employment. After you adjusted for various socio-demographic factors, it was about a 16% lower odds of being employed and working among people with long COVID compared to people without long COVID. Next slide, please. So that's the first part about diagnosis. The next two parts are shorter, but going into what we know and the recommendations around assessment and diagnosis. Next slide, please. This is the second part of the series we published, and the key word here is modifiable. So there are more than 200 symptoms that people have reported in association with long COVID. Some of them we can do things about with medications or other non-pharmacological strategies, and some of them, unfortunately, we can't do much about. So we focused our paper on trying to help people understand what are some of the supportive measures we could put in place among common, potentially modifiable symptoms. And by far and away, this fatigue and post-exertional malaise is the most commonly reported symptom among people with long COVID. And David Kaplan is going to talk to us a bit about some of the 4Ps framework to treat that. But ultimately, you need a structured activity program that's sub-threshold below people's triggers for that post-exertional malaise to be able to support their exercise intolerance. And then these other symptoms that are common, there are many typical medications that I think many of you would be familiar with around treating shortness of breath, sleep disturbances, typical mental health issues, and palpitations. We can refer you to the article to look into that in more detail or talk about it today in our discussion. Next slide, please. This is what I wanted to update you with, and I hope this is practical. This is an overview. So we came together about a month ago now from experts across the country and people with lived experience, and we're trying to provide some guidance to clinical practitioners around how to work up and manage people, particularly if they're presenting with cardiovascular symptoms. So those are, chest pain, shortness of breath, palpitations, fatigue. In that case, could be cardiovascular related. And so this workup slide applies to, people with cardiovascular symptoms, but I think could actually apply to a lot of others in our clinical practice. And I'm going to go to the next slide just because I want to focus on the practical advice here. So this Delphi panel that we ran and got consensus, these are the things that we agreed upon around what to do when you're seeing somebody in your office. And the history components, of course, you're doing a thorough screen for any symptoms, but the ones that are more specific to long COVID are these post-exertional symptom exacerbation, or PESE, post-exertional malaise is another term for it. And really just asking people if things get worse after limited exercise or even cognitive activities. Myalgic encephalomyelitis or chronic fatigue syndrome is common. Up to about 50% of people will meet the criteria for ME/CFS. So we're screening for that on our history. And POTS is quite common among people with long COVID. And so we're always screening for that orthostasis type symptoms to then guide our physical examinations. Physical exam, the key components beyond a general sort of physical exam would be to do these resting and orthostatic vitals, but really the 10-minute standing test, the one I just described to you before, is critical as a physical exam screen for POTS. And really the resting and orthostatic vitals aren't sufficient to rule in or rule that out. So we really recommend the 10-minute standing test if people are having any symptoms of orthostasis. And then because there are cardiovascular complications that can arise, we do a careful volume assessment exam. You'll see here on the right that it's actually quite a limited panel of diagnostic tests that we would recommend. So this is where we say, how far do you go to rule things out? But really, in our experience through the clinics that have been running now for over 2 years, these are the minimal investigations you need for people presenting with cardiovascular symptoms. And beyond that, unless there are any red flags around serious cardiovascular complications, you can probably stop with just these 6 investigations if they're all reassuringly normal and focus on management at that point. Next slide, please. So getting into the treatment and how we can support people to finish this part of the discussion off. Next slide, please. The first thing I wanted to highlight, just in case you're not aware, the Ministry of Health actually recently just introduced, about a month ago now, a new diagnostic code that's 081 for long COVID and post-COVID conditions specifically. And I really encourage you to start using this when you're assessing and treating people with long COVID, because from a research standpoint, it helps us track health services and outcomes at a population level. And we need these types of codes in the system to develop algorithms to identify people in administrative health data. And more on the clinical side and patient-centered side, that when people are using this code, it's an acknowledgement and a testament that they believe that the patient has this condition. And these types of diagnostic codes can also support disability applications and other issues related to their long COVID. Next slide, please. So again, this is part of the Delphi process where we've tried to provide an algorithm or a stepwise approach in how to manage and support people. The far left there, I think the most important thing right now, until we have more clinical trial proven evidence, is simply to take the time to listen to people and validate their experiences as real. A lot of people have felt that they've been dismissed by the healthcare system, and that's challenging in a busy clinical day, but it really does, I think, serve to help people get through their issues, that they feel that they're not alone and that their healthcare providers are there with them. These slides are available, so I'm not going to walk through it all, but if you go to the next slide, I just want to highlight one focused point. There's the importance of, again, screening for and determining whether somebody has post-exertional symptom exacerbation or post-exertional malaise, again, whereby simple cognitive or physical efforts can lead to debilitating fatigue about 12 to 24 hours after they engage in those activities, or worsening of their symptoms. And people who screen positive for that, exercise can be harmful to them, and they really need to pace themselves and rest. And then when able, if they have access to these rehabilitation supports, which Gary's going to talk a bit about, and David as well, but this unsupervised exercise can be very dangerous for them, and they really need a supervised sub-threshold structured activity program with these energy conservation strategies that David will talk about. And that is, I think, where the key differentiating point is in the management of many of these people. About 30% of people with long COVID will suffer with post-exertional malaise or symptom exacerbation. So it's a large minority of them, and it's really key to screen for that. If they do not have that post-exertional symptom exacerbation, then we can work on trialing exercise to really try to maintain and restore their functioning while we're supporting their other symptoms that are causing issues for them. And then lastly, this idea of cardiac dysautonomia with inappropriate sinus tachycardia, which is IST, or POTS, postural orthostatic tachycardia syndrome. There are guidelines from the Canadian Cardiovascular Society on that. And really the non-pharmacological strategies talk about fluids, increasing that to 3 to 4 liters per day, up to 10 grams of salt per day, which is quite a lot, but been shown to be helpful. The use of leg and even abdominal compression stockings. And then really when you're getting into the higher order pharmacological therapy, beta blockers, pyridostigmine are proven to be really helpful in these folks. And then there are others there listed. And that might be the point where, depending on your level of comfort, you may refer on to cardiology if somebody has POTS, or general internal medicine to help you if in need. Next slide, please. There's a lot of questions I get about prevention, and there's some evidence that's helpful, and I think there's some evidence that will be coming. So I think the most important thing is that every SARS infection that we prevent is reducing the risk that somebody develops long COVID. So continuing to do our preventative infection control practices is key, especially when there's surges in community prevalence of SARS-CoV-2. Those are things like masking and improving air quality indoors. Vaccination, there's mixed evidence here. So if somebody is vaccinated before they were infected, the evidence suggests that there's somewhere between a 15 to 50% relative risk reduction in developing long COVID. Now that's becoming less practical because 73% of people in Canada apparently have been infected, according to the latest Canadian Blood Services report. So when we're talking about, does vaccination after someone's had their initial infection or after they've developed long COVID help, there the evidence is really uncertain and not a lot of effects being shown one way or the other. Most importantly, I try to reassure people with long COVID that there does not appear to be any harmful effects or exacerbation of their symptoms if they receive vaccination after they develop long COVID. Paxlovid, I can never say the generic name, but I've put it up there, so forgive me for using the brand name. But Paxlovid, there's a lot of interest and excitement about. There is no trial evidence to suggest that Paxlovid actually improves outcomes in people with long COVID, but there is some preprint evidence that, again, is not yet peer-reviewed that suggests that it might help prevent long COVID in the future. There's also an interesting secondary analysis of a trial that showed metformin had some early promise. And again, these are not trial proven evidence, but some hope on the horizon, I would say. And then, of course, corticosteroids like dexamethasone, which are a mainstay of severe COVID infection, because the trials were stopped early around the acute treatments, we are uncertain whether those actually help in preventing long COVID in the long term. Next slide, please. So just wanted to finish off here by just giving you a glimpse as to all of the work that's going on in the background. There's a ton of research trying to accelerate our understanding and treatment of people with long COVID. Myself and Angela Chung in Toronto we just received Health Canada approval and are hoping to enroll our first patients in the next couple of weeks in a trial that we call Reclaim. This is a platform trial, so we're testing more than one drug therapy at the same time. And the primary outcome here is really patient-centered to try to improve their quality of life. And so we can provide some contact information, or you can email me if you have patients that are interested in participating in a clinical trial, which is also designed as an embedded clinical care pathway. So we look after them while we're conducting the trial to support their long COVID. Next slide, please. So just to wrap up the story of Mr. LC, for his post-exertional malaise and exercise intolerance, I've referred him to one of my colleagues named Adam Brown. He runs it's a private physiotherapy clinic called Cornerstone. Again, not meaning to endorse his clinic, but we are trying to work on the use of biometric data, so resting heart rates and heart rate variability as an objective guide with patients' symptoms to titrate people's exercise and rehabilitation. And the initial results are really promising, but again, this has not been formally studied, which is what we're working towards. For his orthostasis, we did get consensus from our group that even if they don't meet the clinical criteria for POTS, that these non-pharmacologic strategies can be used. And so we've put him on salt and fluids and compression stockings. Orthostatic pacing, I'm happy to talk about later if those are interested. His GP is doing a great job managing his anxiety, which they've had a long-standing working relationship with and have tried different therapies. So we work together to support him on that. For his insomnia, he uses Rescue Zopiclone, which is guideline directed for insomnia, but he tries not to use it on a regular basis, only when he finds that he's really having a tough time and needs just like a day of it to catch up. He did go on and get his 4th dose of his bivalent vaccination, and that did not cause any issues, and so he's comfortable with that. And through some advocacy that I did with him in discussing with his disability, his insurance company, we were able to get him his long-term disability supports, so that he's able to financially support himself. Next slide, please. So in summary, post-COVID is a relatively common condition, sadly. And female sex is the strongest independent risk factor that we know of. And I think it's really important to recognize that these adults who are infected are in the primes of their years, in their career and working years, as well as their family and caregiving years. And so it's not just simply a disease of older adults like we see in many other chronic conditions. Many people continue to experience disabling symptoms that go beyond a year. So there's hope that you might recover within a year, but there's also some concern and follow-up needed for people because it can carry on. There are promising interventions for prevention. Vaccination is the mainstay so far, and there are trials going on testing new therapies, including our Reclaim trial that's about to launch. And I think just, one of the most important messages that I hope we can take away from this morning is that you, as our primary care colleagues, are really the foundation of the support and management for people with long COVID. And I know more resources are needed to support you in this regard, but I hope that you feel confident to be able to look after your patients, because it really is the bedrock of their care and really where their care needs to start. And only for the most difficult and challenging cases where you can use sort of a stepped care model to get that specialized care. Because as you're probably already aware, that's very limited in Canada, and the wait times to get into these specialized clinics is quite long and growing. So with that, I'll just say thank you so much for letting me take you through this. Next slide, please. And a huge thank you to all of these people who have worked on this with me and support our research and clinical efforts. And with that, I will turn it over to you, Tara, and to carry on the conversation this morning.
Thanks so much, Kieran. That was a wonderfully comprehensive talk. I know many of our colleagues appreciated it. I think we have about 8 minutes for some questions. There are a lot of questions in the Q&A, so maybe Kieran, if you could do some rapid fire answers, that would be super.
Sure.
I'm going to pose the questions to you and you can rapid fire answer. And then after that, maybe you can actually answer some of them through typing. But I'm going to start with a question from, Carrie Bernard. Are there any medications we should be considering other than for treating symptoms, e.g. beta blocker or salt? My patients keep asking about treating microclots. Am I supposed to be investigating for such clots or treating them?
No, a great question. I would say the answer to both of those is no. So the detection of microclots has really been only on very advanced and not accessible types of scans. So it's not a CT pulmonary angiogram, for example. You're not going to detect them on that. I am a less is more kind of a physician. And so I generally rely on very high, like on higher order level of evidence when I'm trying this, especially these medications like anticoagulants. There is a trial going on in the world looking at rivaroxaban in the treatment of them. And until those results tell us whether it's effective or not, I generally recommend against any of these in an experimental fashion with my patients. I mean, there is a role for shared decision making, and I think that's really important when we have limited evidence. So, it's obviously up to your own personal comfort level, but recognizing there is no trial evidence to prove these are efficacious, and there are certainly risks that we're aware of, and so that's a decision that you'll have to make with your patient if you feel comfortable.
Great. So then another question here is, how can we differentiate between long COVID and other chronic conditions causing similar symptoms such as somatic disorders, mood disorders, fibromyalgia?
That's a really challenging question, and it's an important one. I don't think there's any clear answer. We for example, we don't know the operating characteristics of the current diagnosis for long COVID. For example, its sensitivity or specificity, or some of these others have been worked out. So, and it's quite a broad definition that captures a lot of things. So I think, in the end of the day, what really matters is what can you do to help modify whatever the patient is experiencing. If it's a flare of their fibromyalgia, or you think it might be long COVID, that's just going to be a determination you'll have to make on the balance of probabilities. But there is no diagnostic test that's going to tell you one way or the other. And I would say it's probably up to whether they're similar symptoms that they had before for their fibromyalgia, for example, flared and got worse, or whether they have a whole host of new things coming up that might point you towards a diagnosis of long COVID on top of their pre-existing fibromyalgia or other somatic conditions that you mentioned.
And so Alan Girl asked, what are you looking for on the 10-minute standing test?
Yeah, so it's actually quite difficult to get clear guidance on the internet about that. So in this paper we've submitted, we'll hopefully provide some clear steps. But you are looking for two things. One, that they have a change in their resting heart rate of an increase of 30 beats per more when they stand up, and that is somewhat persistent in the first 10 minutes that you're measuring it every minute. And the second is that they do not have a drop in their blood pressure. So it's not hypotension, it's tachycardia with maintained blood pressure. And the patient is feeling quite symptomatic, orthostatic. So they say, I'm feeling really dizzy, I'm feeling lightheaded when they're standing up there for 10 minutes. And those symptoms are persistent over time. Their heart rate is elevated over time, and their blood pressure doesn't drop. That is POTS. And that's where that reflects an underlying cardiac dysautonomia. And those are the treatments that we talked about today to help support that.
So the next question is there a difference of long COVID from different variants? So the original strain versus Alpha, Delta, or Omicron?
Yeah, I wish I had a better answer to that other than to say we're not sure. There's some evidence to suggest that there's a lower risk of long COVID with the more recent variants. So for example, they did a study in the UK that compared Omicron to Delta, and Omicron had a lower risk of developing long COVID compared to Delta. The problem with those studies, though, is that there's so much mixing or confounding about various immunity levels at any given time. And also the severity of the disease appears to be on that pathway to developing long COVID. And so it's not clear whether people are developing long COVID because they had really severe disease with earlier variants and less immunity, or if it's actually something about the variant itself. We're trying to do some work to disentangle that in our research, but the answer to that right now is still unclear.
Thanks, Kieran. Someone notes that 10 to 20 years after contracting some of the, and they list some viruses, these have all resulted kind of in cancer that we've learned. So Hep B and C causes liver cancer, HPV, genital anal head and neck cancers, HIV, Kaposi's sarcoma, and they've given a few examples. And I guess there's a question there that, do you think COVID could cause cancer among other diseases?
It's a difficult question to answer. It's a great question, but it's a difficult one to answer because long COVID and COVID have only been around for 3 years now. So we don't have that experience of long-term follow-up to know whether that's truly going to be a risk. I think that we may see some element of that in the future for 2 reasons. One, that we believe there's this sort of chronic uncontrolled inflammation. And we know that many of those conditions that you're talking about, where we know an association with cancer, that inflammation sort of contributes to that development of cancer in that case. So I think we may see it. How big that magnitude is will be, remains to be seen. The other is that we see lots of associations with other chronic conditions like heart failure and dementia, for example. And so why would cancer be spared in that sense? But again, we really need long-term high quality follow-up studies to truly determine the risk and whether that risk actually exists.
Thanks, Kieran. So one last question, and then I'm going to ask if you could just take a look at the chat and the Q&A while David is talking. So Patricia Gagnon asks, any role for stimulant medications for brain fog?
I haven't seen any evidence. If you've seen some studies, I would love to have them passed along. I haven't personally seen any evidence to support that theory. The trials that I've seen going on that are trying to treat memory impairment and cognitive issues are not using stimulants. So I don't have a better answer than that. But if you've seen something, I would love to see it, and I'm happy to follow up with you about it.
Thank you. So I hope you don't mind we've shared your email because folks have requested that. And people have also asked, how can they refer to the Reclaim trial? And there's just feedback in the chat. And then, so what we're going to do is we're going to bring up David's slides next. I will just say as a reminder to folks that we're going to focus on answering questions related to long COVID. We have until 9:15, so we'll have David and Gary go, and then we'll go back to some Q&A. But in the meantime, Kieran can answer some through typing. We won't be answering the questions related to vaccinations more generally, or COVID more generally today, really just focusing on the long COVID. So David, I'm going to turn it over to you. And I will just note that there are some people asking kind of about resources. So hopefully we will, to note, we will be talking about that as David closes his talk.
Sure. Absolutely. Thank you so much. It's good to be back. This is a bit of an update on the primary care guidance that we re-released or updated based on the evidence and based on the science table brief. This was in December of last year. If you move to the next slide, so some of you may remember something that looks like this, because this is really what the first version of the guidance looked like as well. We've updated it in a few ways. This is a 3-page piece of guidance that is available for download. We'll make sure we post the link. I can tell you that we've uploaded it in the past to EMR systems, and we hope to do that as well. Unfortunately, at Ontario Health, we don't have access to the cloud of forms for each of the EMR systems, but we work with a number of our partners to try to do that for people. Because it is helpful, I think, to sometimes just have this right in your chart. You'll see on the next 2 pages, all the resources are hyperlinked, so it's easy to get to things if you just click on the hyperlinks. So if you go to the next page, I'm going to just talk about the updates in this guidance. So we updated the definition of post-COVID conditions as symptoms continuing for longer than 12 weeks based on the PHAC documentation. We really put much less emphasis on PCR testing as it's no longer widely available in the province, but it is important to ask about reinfection and vaccine status. We know that being up to date with vaccination reduces the risk of developing long COVID. We also caution on the use of any sort of exercise testing. You'll see in general, there is really limited testing that we recommend. The testing is all based on symptoms, but we actually have a lot of opinion and some expert advice that suggests that exercise testing may actually exacerbate symptoms for people who are suffering from post-exertional malaise. Next slide. For people with fatigue or post-exertional malaise, it's really important as family physicians that we discuss the 4 Ps of energy conservation. So there's a lot of supportive care that goes into managing the vast majority of these patients, and the people who do have post-exertional malaise. The 4 Ps are pacing activities to match energy level, prioritizing activities that are the most important, positioning to modify activities to make them easier to perform, and planning ahead to allocate for breaks, rest, and relaxation. Many of us are very familiar with this with some other chronic conditions like post concussion syndrome and other things. So not surprising that this worked in post-COVID condition as well. Next slide. We moved away from using the term brain fog, as we feel that it can sort of minimize the impact that the symptom is having on our patients, and we're describing it as cognitive changes, so memory, attention, and executive functioning. And then we recommend a referral to an interprofessional rehab program if available, based on a post-COVID-19 functional assessment score of 3 or 4. I'll show you that tool in a moment. The issue, of course, in Ontario is there is very limited access to interprofessional rehabilitation programs that are OHIP covered. A number of sites across the province during the pandemic reallocated hospital resources for programs that weren't running to run these programs. If you have third-party insurance, then often you can refer those patients to a number of private rehab providers that are running interprofessional post-COVID-19 rehab. Next slide. So this is the post-COVID functional status scale. It's self-report. There's very few questions to ask. And the recommendation is that, if a patient is grading their function as 3 or 4 after 12 weeks, it's appropriate to refer them on for interprofessional rehabilitation. So really there's those 4 questions. Can you live alone without any assistance from another person? If yes, are there duties at home or at work which you're no longer able to perform by yourself? If yes, that's grade 3. If it's a no, you ask them another question. Do you suffer from symptoms of pain, depression, or anxiety? If that's a no, it's grade 0. And if it's a yes, you can differentiate between grade 1 and grade 2 with, do you need to reduce or avoid duties or activities or spread these over time? So it gives you a sense of how to measure functional impact of post-COVID condition in your patients. There is a link to this. You'll see in the next slide. So this is page 2 of the guidance. All of the tools are hyperlinked, so you don't need to worry about where to find them. If you just download the PDF, you'll see all the assessment tools that probably most of us are familiar with, the cognitive ones, the mental health ones. You can see the balance testing, the orthostatic heart rate assessment, the exercise capacity, all there. And the next page really is a list of management resources, some others, very condition-specific assessment tools if you want to do a more detailed assessment, because these are the symptoms your patients are complaining about, and then the rehab and patient resources. So we've linked to 4 different very useful websites with patient resources for self-management. And that's what I have, Tara.
Thank you very much. So David, I wonder if maybe what we'll do is we'll just go to a few resource slides, and then I'll just ask you if you can answer a question that's come up in the Q&A after that.
Sure.
So let's go to the next slide here, Olivia. So just to let people know that the OCFP has also done a terrific job compiling lots of practical resources for long COVID, and I know they're continually adding to that. Note that, one of the things we're going to be talking, Gary's going to be talking just shortly about tips for ODSP applications for people with long COVID and guidance on income supports. And some of that information is available on this OCFP hub as well. Next slide. And Kieran, I know you wanted to just mention these clinics. Did you want to speak to this briefly?
Sure. Yeah, I'm just trying to address people's questions in the chat as well. So CADIF recently released a report like a couple weeks ago, I think now, that gave it was an environmental and jurisdictional scan of these specialized clinics and professionals across Canada. What you'll see is, unfortunately, there are simply not a lot of them, and some of them are closing because of lack of funding. But it is still a good resource, I think, for you to understand where these clinics are located in Ontario. That might help you connect with them if you want to refer your patient. So it's readily available, and perhaps the team could provide the link as well to our audience. But it's a good resource, I find.
Next slide. And then this was just a reminder, I think, that we have a number of e-consult specialties that we can access that can support long COVID. And I think actually there's someone in the chat reminded us of that as well. Next slide. Kieran, did you want to speak to this one?
Yeah, so I just wanted to this is not so much resources that you can plug into for your patients, but a lot of people feel like there's no hope on the horizon. And I think we need to do a better job as researchers is communicating what's going on before it's finished. But we just came together. There's a big announcement coming up about this around formation of this national research network. There's more than 300 of us, including many people with lived experience. And so this national research network is really trying to accelerate care in Canada. And it's centered around these 4 pillars, looking at biomarkers in the basic biomedical sciences, clinical trials and cohort studies to help people with new treatments. I'm leading the health services research, which is trying to understand the best integrated care pathways to support people. And then there's a population health focus that's really focused on equity and economic impacts. And of course, we're an integrated network. So the 4 pillars talk to each other and support each other's research to make sure that we're all aligned. So if there's any interest in getting involved in that, it's an open invitation to anybody. Please feel free to reach out. The website is there, or if you just simply want to learn more about what's going on with research in Canada.
Thanks, Kieran. So I think that I'm going to ask David the next question just because we're on this, and then I'm going to go to Gary next. So, and Kieran, while you're answering questions, can I just make a request? If you could answer them in the Q&A portion.
Oh, my apologies. Yep.
And if you could just sort by most upvotes and answer the questions with the most upvotes first, that would be terrific.
Thanks, Tara. Sorry about that. Yep.
And David, the question to you is, where are we at setting up long COVID care centers? Well, this is actually for both you and Kieran.
Sure.
Long COVID care centers for assessment and treatment covered by OHIP. Obviously there's limited time in family medicine, and it's of course important for those who don't have family doctors as well, and who can't afford physio, etc.
Yeah, no, it's a great question. As I mentioned, over the course of the pandemic, a number of these had been set up. What's happened is the lack of funding has resulted in either the amalgamation of existing programs or closure. There is one program in the province in Toronto providing virtual service to anybody in the province. The program currently receives about 60 referrals a month, and the wait list is about 6 months to be seen. But it's interesting to see that like the quantum of people who actually need referral seems to be lower than I think what we may expect. The problem is that these are very resource intensive referrals. The programs in OH East and West, the wait lists are now at about a year, and there's no programs in the North. As I mentioned, the patients, many patients are being referred to outpatient rehab with either moderate or severe impact on functional ability. But there are many Ontarians that have third-party benefits, but I think where our concern is, and Kieran and I were just chatting about this, is the equity of the people who can't afford rehab for themselves, or just don't have any access to third-party benefits. And we do have to remember that rehab is not an OHIP funded service for most people. It's funded for people for kids, and it's funded for people over 65. That was a decision made many years ago by the government around even around physical therapy. But we are working with the government to really understand what is going to be the best model to make sure that from an equity standpoint, people in Ontario have access to rehab services. So don't have an answer just yet, but I can guarantee you that a number of very smart people are working on this currently and really trying to come up with a solution for here in Ontario.
Thanks so much, David. So I think that's a great segue actually to Dr. Block's talk. So we'll go to the next slide here, and I'm going to turn it over to you, Gary, because I know you're going to really talk more about these equity issues. And also there's been a lot of interest in how we can support our patients to access disability programs.
Yeah, thanks so much, Tara. I'll say that, I'm going to just touch on this issue of the connection between long COVID and access to disability support programs, which I think has been a real challenge. And in fact, it's a really interesting and in many ways a new type of story in the disability income support world, given that we're dealing with a rapidly emerging new and significantly disabling condition. I will say up front that one of the best things we can do to support our patients is just access the resources that have been put forward today and start to use these tools. But obviously easier said than done. But I'm hoping that will become integrated into practice over time. I will also say that while I spend a lot of time looking at income support programs, I'm not a particular expert on long COVID, but I've drawn support from quite a number of people who are doing a lot of work in this area, from the legal aid world and from the rehabilitation world, to support this. So next slide, please. So this is an issue that has gained a lot of attention in popular media over the last year, really. Some of the stories coming out are actually quite distressing, talking about really the kind of added stress that not having access to adequate income supports places on people's lives. I mean, you'll see in the second article the story of a woman who actually considered applying for MAID because she had long COVID and just did not have the income support to allow her to deal with her condition appropriately. Next slide, please. I also think it's really important in kind of framing this out to remind ourselves that whenever we talk about income supports, we are talking about poverty. And when we're talking about poverty, we're really talking about different degrees of social marginalization and the intersections of those social marginalizations. And we know, and I think many of us have heard this story, that COVID has highlighted the types of inequities and the complexities of inequity in our society and how they play out on health in a sort of concentrated way that we haven't seen very often. And this excellent report from the Wellesley Institute from a few months ago really laid out the story around this quite clearly, both in terms of the incidence of COVID being much more prevalent amongst certain parts of our community, outcomes being worse, and then tying that into long COVID, right? And the expectation that this is a condition that likely will impact socially marginalized groups far more than others. And Kieran alluded to that as well. And next slide, please. And this report goes on to make a specific call to those who run income support schemes, asking them to make sure that they are able to adjust their schemes to the realities of long COVID, right? And this is a process that is very live right now. These adjustments are really going on in real time. So next slide, please. And a reminder before we get into this, that when we talk about disability income support schemes, we're talking about a whole range of programs. These are federal programs, provincially funded programs, employer-funded programs, and privately funded programs. It may be surprising to some, but you'll see that ODSP, social assistance-based programs, are really only just over a quarter, or provides just over a quarter of the support for people with disabilities in Ontario. So just to really keep this in mind, I will also say that, in family practice, we really interact with all of these programs on a regular basis. Next slide, please. So in terms of the specifics of applying for disability income supports with long COVID, I think there's a number of real challenges that present themselves. And I've kind of summarized them down here, but just in brief, and I know some of this has come up in the Q&A and the conversation already, but the challenge of proving diagnosis, right? We stopped testing for COVID routinely for the general public a long time ago. Disability support programs still are asking for the proof of a COVID diagnosis and its link to symptoms, although that is starting to shift. The issue of determining prognosis with a condition with which we have very little experience still, disability support programs still want us to look in our crystal balls and predict how long a disability is expected to last in any particular individual. Very difficult. The challenges that we face in objectively providing the evidence of the impact of invisible symptoms, right? The kind of things that have been laid out so well today, but the cognitive changes, the fatigue, the mental health impacts, this takes time and it takes a lot of nuanced work to do this well. The lack of access to specialized care, right? These disability support programs really like specialist referrals. We know it is incredibly difficult to access specialist care with expertise in long COVID. And finally, the patient-oriented barriers, right? The fact that people who are experiencing these symptoms often face a very difficult uphill battle in terms of engaging with the complexities of these types of application processes. So next slide, please. So I want to spend a moment just providing a bit of context on the programs we're talking about, because I think that this helps us to sort of frame out our approach to these programs. And I could spend hours talking about this, but I want to focus on one question, which is really the central question that adjudicators are grappling with when they receive our applications and our patients' applications. And that's this one. Does this individual meet a program's threshold for disability? And I got to say, I am not in any way or suggesting that we have a role in determining eligibility. We don't. We're not trained to do that. We don't have the knowledge to do that in almost any case. But the more we know about these programs, the better we are able to help people navigate through those programs, right? And Kieran's example of the language he uses for an ODSP application is an excellent example of how powerful a bit of knowledge can be. So next slide, please. So just to compare two of the most common programs that we access, Ontario Disability Support and the Canada Pension Plan Disability Program, if we look at their definitions of disability, we can see the vast, the huge distinction in these programs, right? The huge spread in the range of definitions of disability we're talking about. For ODSP, they're looking for someone to have a substantial level of impairment. For CPP disability, it's a severe level of impairment. ODSP allows an impairment to be either continuous or recurrent and are looking for a 1-year prognosis for the disability. CPP disability is really looking for an indefinite duration, right? So really a disability that will last beyond the foreseeable future. And ODSP, when it looks at functional limitations, it takes a very nuanced approach to functional limitations in 3 areas: work, participation in self-care, and participation in communities, whereas CPP disability really puts a focus on someone's ability to perform any type of substantial or gainful work alone, right? So I think it's important to keep this in mind as we start to think about how we frame our applications for patients. Next slide, please. And I just briefly want to mention 2 other programs I think we deal with a lot. Private disability insurance, which again really focuses on occupation. So if we're looking at the first 2 years of disability, it's really about someone's ability to complete the duties of their own occupation. After 2 years, it's about their ability to participate in any occupation appropriate to their education or experience. And if we look at WSIB, really challenging one to deal with around long COVID, because they are still focusing on this idea of trying to prove a high risk of workplace transmission. And so I just want to mention that because I think this is a story that is going to play out over the next little while in terms of how we deal with that requirement in the context of a pandemic. Next slide, please. So I'm going to end off here with just a few tips for providers on completing applications. And these are tips, again, that are drawn from the legal, rehabilitation, and healthcare experts I've been consulting with, but hopefully will help you in terms of understanding what will make our applications more likely to succeed for our patients. So first of all, the real need to focus in on clear documentation of functional limitations caused by impairments, and especially those invisible impairments, right? And how they're impacting people's lives, even in very subtle ways. Second of all, a call to really ask about the risk of workplace transmission. And what we mean here is whether or not someone works in what we would think of as a high-risk environment, right? Healthcare is an obvious one. What we've called essential workers, but also think of Amazon factories. Think about migrant laborers living in congregate settings, etc. Third of all, the need to very carefully list the treatments that have been tried with patients, their adherence to those treatments, and also think about some of the barriers to adherence, the reasons someone may not have been able to carry out those treatments, which may be due to symptoms. It may be due to external factors like income, access to transportation, other demands like childcare. Next slide, please. The fourth suggestion is around referring to specialists. This does not necessarily require someone to see a specialist because we know how difficult it is to access, but just showing that we've made the referral can be a very clear indication to these programs of the severity of the disability that someone's experiencing. The fifth is that we make sure we list all medical conditions. We don't just have blinders on about long COVID or the one condition we're applying on, but we make sure we show the totality of someone's healthcare situation, its impact on function. And then finally, the last tip is that we do our best to avoid making cost a barrier. Right. And this is not to deny the fact that we are allowed to charge for those applications that were not paid for otherwise. But it's just to always remember that if someone is unable to pay, we do not want to allow that to become a barrier to a person submitting these absolutely essential applications. So next slide, please. So this is just a list of resources. I think they will be shared later on, but I'm going to leave it there. And hopefully that's given you a little bit to chew on in this complex world, and turn back to the discussion.
Thanks so much, Gary. And yes, we'll definitely be sharing all the resources, the slides, a recording, and also a summary of some of the top Q&A on our website following the session. Most of it is there later this afternoon. Maybe we'll just end slides for a few minutes, Olivia, while we just go for some further discussion. I know, Kieran, you've been answering a lot of questions in the Q&A while we've been talking. So maybe I'll just pull you back though we'll talk about a few of the top things you've been answering questions about. Some of the things I also just wanted to note, I noticed that there were a lot of questions about POTS in particular, and it seems like people also wanted to have more detail about the treatment, how much water, how much salt, the compression stockings. I did want to also mention that we did have Adam Brown and Jennifer Hume and Angela Chung on in September 2022, talking a little bit more about it. So if you were interested in viewing their session, it's on our archive past sessions. So Kieran, maybe I'll ask you to just expand a little bit on some of those practical tips that people.
So yeah, thanks, Tara. So I put I tried to list them in numerical sort of list on the specific treatment guidelines that come from the Canadian Cardiovascular Society for POTS, but it's 3 to 4 liters of fluid per day, where the general recommendations for the average person is like, sort of 2 liters. Up to 10 grams of salt. 10 grams of salt is a lot of salt for somebody to take. So as much as they can get, you're trying to expand their volume, their intravascular volume. And I just use table salt. I just say add salt to everything. It's the only time a doctor will probably ever tell you to use salt, extra salt, because the salt tabs can be quite expensive to buy. And so I just try to give them practical solutions. Compression stockings generally are 30 to 40 millimeters of mercury. Most of the time people, find that quite uncomfortable, and you have to be careful if people have arterial or severe venous insufficiency in their lower extremities, mainly more on the arterial side. So, you can do a screening ankle brachial index in your office to make sure that they don't have serious arterial insufficiency. And then we talk about sleeping with their head sort of at an incline, just to help volume expansion overnight. So those are all outlined in the Canadian Cardiovascular Society's guidelines on POTS, which I'm not part of, but that's a helpful resource if you want to go to that for that list. There was a comment brought up, and I just want to disclose, I don't have any financial connection to Adam Brown at all. I help him, and he helps me with our patients, but he is a private, for-profit enterprise. Him as a person he's a really dedicated individual. He just is doing this off the side of his desk because he wanted to try to help people, and he thought he had some knowledge around high performance training and he could apply that to long COVID. But I think it is important to disclose that and recognize that everyone has bias and conflicts. And so I don't have any financial relationship with him. We do research together, but it is a for-profit clinic.
Thanks so much, Kieran. I think I just also wanted to just mention that somebody in the chat with Carrie disclosed that she has long COVID, and I think that she uses potassium because she finds it actually very difficult to take the amount of salt that you said, just using table salt. So Kieran, I wonder if there's anything else you wanted to just mention, given that you've been answering quite a few questions, things that people were, I think the other area, it seems like there was a lot of discussion about and we've talked a little bit about this, about the intersection potentially with chronic fatigue syndrome, with autoimmune disorders. Farah Tabasum had an excellent sort of helpful comment, I think, in the chat as well. She says that ME/CFS is a disease that most commonly arises in a post-infectious setting. About 2/3 of patients had the onset of ME/CFS after a viral infection. For those of us who specialize in this area, we are taking the approach of recommending evaluation for ME/CFS for patients with long COVID whose symptoms have persisted for 6 months and whose predominant symptom is significant fatigue.
Absolutely. No, I mean, I know it breezed over in the presentation, but the consensus from our Delphi panel was that we should be screening people for ME/CFS when they present with persistent symptoms, and POTS and mast cell activation syndrome. And a lot of these all share overlapping symptoms, which I think creates a challenge on differentiating them. But I think what's most important for the patient is that the principles for many of these conditions are either on supportive management for symptoms and really around that energy conservation and structured activity programs are very similar and the same. The post-exertional malaise that people with ME/CFS experience is the same presentation as people with long COVID. And that's where the structured activity program, not graded exercise therapy, but structured subthreshold activities really seem to help with energy conservation.
Great. I did want to just going back to POTS, there have also been some questions and discussion around the impact potentially on blood pressure if you have a lot of salt in water, and some people saying to be careful if it's hyperandrogenic POTS. But anyway, I don't know if you wanted to comment.
Well, there's two things, every recommendation comes with a counterbalance, and there's always risks and benefits. So if people have pre-existing conditions put them at risk for volume overload, like heart failure, for example, right? You have to be very, very careful in recommending a huge amount of salt. And then certainly, with blood pressure and cardiovascular issues, salt we recommend the opposite thing. So it really has to be a careful consideration of what is the most predominant health risk and how does that counterbalance by the risks of the treatments we might be recommending. And on the balance of probabilities, what do we think is going to support our patient best to get them through the issues that they're facing? And that's where I have these sort of very candid and frank conversations with them to have a shared decision-making together to say, look, it's not perfect. We're in a bit of a bind here. What do you feel most comfortable with? And here's what I think the medical literature says. And then generally, if we arrive at that decision together, people seem to feel more comfortable that they were part of that decision rather than just me simply telling them what to do.
Thanks, Kieran. Gary, I wonder if you have any other thoughts that you wanted to share after answering some of the questions directed for you. I know many people found your talk to be really helpful. I also know there are some comments just that people are feeling burdened by just how long, just how complex it is to support these very complex patients who do have a lot of needs and of course, filling out forms. So I don't know if you have any further advice or reflections there.
Absolutely. I was actually just typing a response to one of those comments and then realized that I wasn't sure what to say because, a lot of this really does come back to the fact that we do not have enough resources in most of our settings to deal with the complexity of what we're seeing. Obviously, those who have access to interdisciplinary providers, we need to fall back on those providers wherever possible, but that's not available. And even honestly, in my very well-resourced team, we have difficulty dealing with the complexity of these types of situations. One thing I will say is that if we put the time into developing the kind of basic life foundations that people can draw on, like, making sure they have adequate income support and adequate housing and, other community supports, that will over time take pressure off of us. Because these conditions are, the way they play out is as much social as it is medical. And so I think we need to sort of bring in extended community supports and extended social supports for patients. But it is absolutely that upfront work of the diagnosis, the initial support, the initial building of these frameworks of support that is really challenging. And I think the best I can do is just kind of acknowledge that. And, we're all in that together. I think is really the best I can offer there.
Thanks, Gary. Thanks, Kieran. So I know we're winding up now, and I wonder, Olivia, if you can just bring up our last few slides. I know there's been lots of great comments in the chat just saying how appreciative people are about today's session, how practical it was, full of good information. I know people have been furiously also trying to type answers to the Q&A, so thank you for that. Just a few things that we wanted to just flag for folks, that there is now expanded eligibility for PCR testing, and we've listed this on the slide, and you can refer to it after the session when we post them. Next slide. We've also had at our past two sessions some lots of discussion, I should say, about the ability to pre-prescribe Paxlovid to patients who don't have COVID yet, but who are high risk. So yes, you can do this. You can pre-prescribe Paxlovid to a patient who doesn't have COVID yet, but who is high risk and should receive Paxlovid if they do acquire COVID. But people can't actually get the Paxlovid unless they have a positive test. However, your prescription can sit at the pharmacy. So there is now some more clear wording to support you in doing this with your local pharmacy. Next slide. And some great resources on immunizations. We know we've talked at past sessions too about how we have a lot of immunization catch up to do as a population. And here are some great resources you can share with your patients. Next slide. So our next session will be about a month from now, March 24th, after hopefully most of you have had, if you have children, a nice March break. Hopefully regardless, you'll have some opportunity for some time off and a break from, I know it's been a really busy winter. As usual, we're looking for suggestions for speakers for our upcoming sessions and topics. So let us know what you're interested in hearing about when you fill out our evaluation, which you'll receive shortly. Of course, as I mentioned, the slides, the presentation, the resources will all be available later today on our website, and a Q&A will be available in a few days from now. I wanted to give a huge thanks to our panelists today, Dr. Gary Block, Dr. Kieran Quinn, Dr. David Kaplan, who've given us a terrific session and so much of their time and answered so many of our questions. So thanks to all of you. Thanks to Mehalei Kumanen, my co-host, and to all of our back team who support this event. And thanks to all of you for the incredible work that you're doing. I think today's session really highlighted the important role family medicine is playing in caring for some very complex patients, often without the resources that we really need to do so well. And you're really carrying that burden and supporting our patients when sometimes the system isn't otherwise. So thank you for all of that. And we look forward to seeing you in a few weeks.